We've talked with lots of health plans about utilizing EPSDT specifically for our peer support. And the answer that we got a lot of times was like, we're unclear of how this fits in. We're not sure. We don't know if we can use it.
Elaboration on what those EPSDT requirements look like. And what is cool for all of us, for you, Patrick, Kellie, myself, as a pediatrician, is they really double down on how important it is for states to provide comprehensive behavioral health services to our kids and adolescents.
That aligns also with populations of young people that we feel like deserve some extra attention, individualized approaches, not cookie cutter approaches.
Hello, and welcome to the Self-Disclosed Podcast. I'm your host, Patrick Gilligan, and today we have a really exciting episode. I got to sit down with both Dr. Andrey Ostrovsky, the former CMO of the US Medicaid Department, as well as Kellie Green from CareSource. She's the Director of Child and Family Health there. And we're talking today all about the new sub-regulatory guidance that came out recently around EPSDT and the impact that has for providers, for patients, for health plans, and more broadly across the whole ecosystem. So it's a fascinating topic. We have two experts here. I really hope you enjoy and look out for more. We're going to hopefully be covering more of these. So hope you enjoy.
Okay, amazing. Kellie, Andrey, so great to have you here on the podcast. Today, we're going to be talking about EPSDT and the new EPSDT guidance that came out. And I think the inspiration for this topic was just a general lack of widespread awareness and knowledge of EPSDT. And so the hope for today was to share a little bit more about the new guidance and hopefully help people get a better understanding of EPSDT. So Dr. Ostrovsky, you have probably the most credibility when it comes to talking about this topic. So can you maybe just start by telling us a little bit about what you know about the history of EPSDT and sort of like where it sat prior to this new guidance?
Sure, you bet. The way I would think about the EPSDT benefits, or the early and periodic screening, diagnostic, and treatment benefit, is putting it in one of two buckets that are legislatively mandated or prescribed by Title 19 of the Social Security Act. Specifically, Section 5, for those of you that are really curious, outlines a set of mandatory benefits that the Medicaid program must provide to beneficiaries, or optional benefits. CT falls under the mandatory set of benefits. What that means is that when a state is getting money from the federal government, also known as the federal match, in order for that state to receive those federal match dollars, they have to be in compliance with how the Medicaid program is supposed to be run as prescribed by Section 1905 of the Social Security Act. CMS periodically provides some sub-regulatory guidance to add a little bit of nuance around how specific benefits should be rolled out. So there's statute or law, Title 19 of the Social Security Act. Then there's regulations, which is how the executive branch of government, in this case, the Center for Medicaid and CHIP Services, will say, here's how the law needs to be effectuated. So regulations. And then there's sub-regulatory guidance like a CMCS informational bulletin, or CIB, or a state health official letter, or SHO, a state Medicaid director letter, SMDL. Lots of fun acronyms that basically all mean the same thing. Hey, states, here's how we recommend you go about fulfilling your obligations, mandatory or optional benefits. The interesting recent guidance, which is recent as of last week, is sub-regulatory guidance that CMCS put out, essentially reiterating and emphasizing requirements for children and youth enrolled in the Medicaid program and in CHIP, or the Children's Health Insurance Program, which is basically like a cousin of CHIP, behaves just like CHIP. Elaboration on what those EPSDT requirements look like. And what is cool for all of us, for you, Patrick, Kellie, myself, as a pediatrician, is they really double down on how important it is for states to provide comprehensive behavioral health services to our kids and adolescents.
So Kellie, in your work at CareSource and beyond, what have you seen EPSDT in the past, and where does that fit in from the plan side?
To answer your question, Patrick, from a plan perspective, I think, I can't speak for individual plans, but the industry as a whole right now, we discuss EPSDT in state, it's requirements that we deal with in state contracts. But are we maximizing the utilization of EPSDT? Are we getting everything that we can out of it? Are we utilizing it to make sure children are getting their needs met to its fullest extent? I think the industry as a whole has a lot of opportunity here.
Let's go back to you, Andrey. Why now? Why did this come out now? I know you've been sort of thinking and working on this for a while, but what was maybe what was the inspiration for this, and then why now?
Sure. So many cases, such as in this case, there is legislation that comes out that among the many provisions within a law would state something like, hey, CMCS, you guys should promulgate guidance that elaborates on XYZ priority area. In the case of this state health official letter, that legislative trigger was the bipartisan Safer Communities Act, the BSCA. It's not a particularly piece of legislation. I think it was a couple years ago in 2022 that it came out. And the focus was on school-based health, gun violence prevention, and child and adolescent mental health. With that act of detail, I do remember eyeballing it, but generally, if I don't know an act really well, it means that there wasn't necessarily a ton of funding associated with it that goes to CMS. So that's one major trigger. Besides legislative triggers for sub-regulatory guidance to be put out, there's also a constant barrage of advocacy efforts where folks from the community, provider organizations, advocacy organizations of families and children, drug companies, device companies, you name it. They're constantly lobbying for, advocating for various changes at CMCS, and there's a backlog of sub-regulatory guidance that CMCS has, and when it has a vehicle like a legislatively mandated state health official letter, then they go ahead and plug it in there. And so some of the provisions in this guidance, they've been on the back burner for quite a long time. In some cases, since I was in federal service back in 2016 and 2017, and this form factor was really well timed to put some of those backlog guidance into the letter.
Yeah. I provide maybe an anecdotal perspective as well on this. We've talked with lots of health plans about utilizing EPSDT specifically for our peer support, and the answer that we got a lot of times was like, we're unclear of how this fits in. We're not sure. We don't know if we can use it. We haven't done it before. And so I suspect that bringing more clarity too around the behavioral health aspects of EPSDT, I'm sure there were people who were asking for clarification on that. And it does sound like it's been in the works for a long time. Kellie, maybe we can go to you before we go back to Dr. Ostrovsky. When you first read the guidance, what impact did you feel like it had on the way that you're approaching how you're structuring your EPSDT benefits, or just utilizing it as a general framework?
In regards to this new guidance, it was very promising to me that it especially highlighted young people who are experiencing foster care, because we know that they are some of our most vulnerable youth in America who have the most concerning health outcomes. And children are our future. And so it just makes sense that we figure out every way we can, every lever we can pull to invest in our future as much as possibly can, and to set youth and families up for the most healthy and fulfilling lives that we can. In addition to focusing on children in foster care or experiencing foster care, children with special health care needs was also highlighted in this. And, from my perspective, those two populations of young people are amongst the highest acuity or in highest need, but sometimes aren't receiving the most comprehensive services due to gaps in services array and a variety of other issues. And so for them to highlight these populations, I felt like that was timely and needed, especially considering the youth mental health crisis we're currently experiencing. And so from a plan perspective, that was aligns also with populations of young people that we feel like deserve some extra attention, individualized approaches, not cookie cutter approaches. That was really promising for us. And I also see a lot of opportunity for an industry as a whole moving forward with, they mentioned in lieu ofs and, that in lieu of capability, I think has a lot of promise as well to fund things that might not be covered. So really, it just opens opportunities for us to make sure that children are getting the services they need, again, at the time that they need them, in the place that they need them, prioritizing keeping children in their communities connected to services that will support them, is a top priority.
I want to pull a quote and ask you about a quote from the actual guidance itself, which there was a line that said, states will not be able to comply with EPSDT requirements unless they hit a few different bullet points. But at the end, they said, which creates a higher standard of coverage for eligible children than for adults. Andrey, can you explain why that point specifically was made about requiring a higher standard of coverage for children rather than adults? And then maybe tell, what your implications of this guidance and why you think this guidance is important.
Honestly, I don't know why they're making that distinction of having a higher standard for children compared to adults. There's general underpayment of services for children relative to adults. In some cases, it's justified because on average, kids are healthier than adults, and so you have more disease burden, and so may require more spend to address that disease burden. Having said that, if we're comparing mild behavioral health issues in a child to mild behavioral health issues in an adult, I don't think one is more expensive than the other. I do believe, and it's been proven by Nobel laureates like J.J. Heckman, that the societal return on investment is much higher for children. So I'm not sure if that's like a philosophical driver of that language in the guidance. There is no equivalent of the EPSDT benefit for adults. There isn't that level of prevention or screening that is mandated by statute. So in that sense, I guess that may explain why they're saying this language around kids versus adults. But I'm not sure if there's something deeper underneath of that.
Got it. Okay. So why don't you share with us, what are your takeaways or the implications of this guidance, and what do you think the downstream impact will be, both for plans, for states? And for
sub-regulatory guidance is soft at best. And what I mean by that is states are not going to get financially penalized because they're now, not fulfilling to the letter of the sub-regulatory guidance their own care delivery and payment model. The implication of sub-regulatory guidance can be thought of in three personas or archetypes for a state. You can have a state that is really progressive around whatever the guidance speaks to. In this case, let's say adolescent mental health, and that state already has a program in place, they have a strategy, and this sub-regulatory guidance gives them a tailwind to get more flexibilities from the federal government to execute that strategy. So it's hard to quantify exactly how many states that would be, but let's say that might be, 8 to 10 states. Then there's going to be the kind of like the early majority or late majority the states that aren't particularly progressive, but if there is guidance that's put out when they are submitting for federal approval for funding for a state plan amendment or an 1115 demonstration or 1915 demonstration or 1115 waiver, the feds will say, oh, okay, you are asking for XYZ flexibilities. Well, we'll give you those flexibilities, but what is your answer to our recent sub-regulatory guidance around this EPSDT benefit and mental health? And then there will be a dialogue between the state and the feds where the state will then have an answer to how they're going to fulfill the promise or the kind of sub-regulatory guidance. And sometimes they'll include language and modify their original request, or they'll say, thank you for the feedback, but actually it's not appropriate for us at this time to change the way we're doing payment or delivery. And then the feds will say, okay, cool, thanks for thinking about it. So that's the second bucket. The third bucket of states are going to be somewhat regressive. No matter what sub-regulatory guidance you put out, they are not going to change. Sometimes it's because of political reasons, and the political reasons might be cost containment. Sometimes the political reasons are way more nefarious, and it's things like classism or racism. And so you can have a state like, Texas health outcomes. Oh boy, my friends in Medicaid that work there really are doing their best, but the state legislature is not giving them a lot to work with. And so you have a state like Texas that's going to apply for a state plan amendment. The feds are going to say, hey, we just issued this guidance. What are you doing to ensure optimal behavioral health outcomes for your kids? And the state regulators are going to be like, well, our legislature said that we're just not going to fund any of this. So yeah, no, we're not going to do it. And in theory, CMCS could say, well, we're not going to approve your state plan amendment. But then what happens is the governor goes to the senators or House members and complains, and then the senators or House members write an angry letter to the CMS administrator, and then the CMS administrator is like, wrong, I guess we have to approve it. And so states have a lot of leverage, and if a state has dug in its heels, no, it doesn't matter what kind of sub-regulatory guidance you put out there, they're just not going to do the thing. So three personas: more progressive, middle of the road, kind of laggard or regressive. And there's a lot of flexibility in the Medicaid program, and there's a lot of interesting dynamic back and forth between states and feds. But it's really, what does the state want to do? That's what's going to drive policy. And I would view sub-regulatory guidance almost as a permissiveness or a tailwind for which policies will get advanced faster. And the final note I'll make is, if a state really wants a policy to move forward, it's more likely than not that it will move forward. But what the feds can do is say, hey, go back to the drawing board 10 times. So either the state goes and spends 7 months to get something approved, or it takes 27 months to get it approved. And that's the tacit power that the feds have.
So Kellie, you can correct me if I'm wrong, but I assume that you're interacting with the state Medicaid plans mostly. How have you seen them bring these sorts of things that are not necessarily requirements, but are that more tailwinds or suggestions or directives from the feds? How have you seen them interact with these? And have you seen a similar sort of openness and resistiveness across some of the states that you operate in?
Certainly, working across states is a really interesting and unique experience in each state. You've seen one state Medicaid plan, you've seen one state Medicaid plan. Same goes for child welfare. In the different states that we operate in, or even that I've operated with prior to my position right now, it is certainly different experiences depending on the state that you're in. You mentioned Texas before, and I think that I'll bring it up again. And I think that, this EPSDT guidance could potentially support states like Texas who are finding themselves in class action lawsuits due to not being able to provide children in foster care with the necessary physical or behavioral health supports necessary. And this is concerning. Again, these are our most vulnerable children in America, and they are taken from their homes and everything they know and love for the promise of safety and care. But then sometimes, not always, when they enter care, they're actually not getting the healthcare services that they deserve to get, that they are entitled to get. And there's something wrong with that. And so with this EPSDT guidance, I feel like it could be potentially leverage for states who are finding themselves in class action lawsuits in which they are not meeting the needs of these youth, to start to look at how do we leverage EPSDT to expand our service array, expand the number and types of providers that are serving these youth, and how do we, make sure that they are getting their needs met, especially when we think about what's going on in youth mental health. And, unfortunately, a child might have some kind of, they might become dysregulated or have some kind of crisis occur, and they present at an emergency room to get this support. Well, then, you're running into what we're seeing in a lot of states is ED boarding, where they are kept in a hospital for several days because they can't find services in the community that will ameliorate or, prevent further, issues. And so that's an issue too. There's just not enough services and supports in communities to keep children safely with their family, to meet their needs, especially when we're talking about children with special health care needs. There's so many families that are desperate for additional supports. They need these. They're begging for them. They're asking for them. And when they spend year after year after year not getting what they need to keep their children safe and healthy, then we run into bigger issues. Sometimes families will feel the need to surrender their child to child welfare and foster care because they think it potentially could get them more services. And that's simply false and not the case. So, even young people who are seeking certain residential treatment for mental health issues, there's so many of these kids are being sent out of their home state to get the treatment they feel like they need because their state doesn't have it in-house. And I don't know about you, but I have children, and I cannot imagine sending my kids to another state without me to get the care that they need. So, the opportunity here should be grasped and urgently done so to meet the needs of these kids.
Kellie, it's great. And I think back to you, like who do you feel like this empowers? Does this empower you as a plan administrator trying to bring better services to your members? Is this empowering to, as Andrey points, the states that are maybe in the middle and the proactive? Like who is this empowering to?
Great question. First and foremost, this should be empowering families. This benefit is for families. Many families don't understand Medicaid because it's super complex, and we don't do a great job of explaining the rights that parents have and the benefits they can attain in plain language. I've worked in Medicaid for years, and the verbiage that we use and the language is complicated even for me. And so how are we expecting families to understand what they are entitled to when we don't do a great job of explaining it, nor do we do a good job of putting out culturally relevant information for a diverse group of families to consume? So that should be, this is an opportunity for us to also, focus on that population and really help them understand. Second of all, I think this is an opportunity, from a payer perspective, we just want to be good partners to the markets in which we operate in, the states that we're operating in. And this is a great opportunity for payers and states to come together to say, okay, what can we accomplish together? How can we get creative? How can we utilize this to all of our benefits to enhance health outcomes for children? So I think, both from a payer and a state perspective, this will help us fill service gaps. We need to educate even the provider space on this benefit and how to understand it and utilize it appropriately. I think there's opportunity there. And I'm sure providers want this. Well, I'm not a provider, so I couldn't speak for them. But, better understanding of how to support the patients that they see, I would imagine a lot of would be attractive to providers. So, I do think it's an opportunity for a variety of
one thing, if I could chime in here.
Yeah.
Kellie, you mentioned Texas had a lawsuit, and speaking of children, there might be a 9-year-old that barges in momentarily. So just the heads up. Texas had a lawsuit, and there was one, I know at least in the ABA space, that changed Texas's approach to coverage to make it a more generous approach to coverage. There was a landmark case called Witt versus United Behavioral Health, where the United Behavioral Health was, it was a concern about access and too much prior auth, and that sparked some momentum to reduce prior auth requirements. And that brings me to a very interesting, not sub-regulatory guidance, but regulatory guidance that just recently dropped as well. So there was a rule finalized by not only HHS, but also in partnership with the Department of Labor and the Department of Treasury. It was NEF, for those of you that want to Google it. But essentially, as a friend of mine who's the chief behavioral health officer at a national health plan called it, it's the red tape filled bureaucratic government applying red tape to health plans to avoid them doing prior auth. In other words, this rule essentially is, and Kelly, I'm curious your thought on this rule. This rule is saying to group insurance plans, so commercial insurance, not Medicaid, group insurance plans, hey, we're going to make it so burdensome for you to create prior auth or other utilization management approaches that plans are basically throwing their hands up in the air and saying it's just not worth doing all the utilization management because of how bureaucratic it will become. And so they're actually increasing access because of that red tape. And I think this is creating a really interesting synergy where the state health official letter is creating a tailwind for kids with behavioral health needs whose care is reimbursed by Medicaid. This rule, not sub-regulatory guidance, but regulatory guidance from HHS, Labor, and Treasury is, through a different mechanism, improving access to behavioral health services to adults and kids on group insurance plans. And I wonder if that might be an opportunity to build on what Kellie's saying, like, hey, if we can mobilize families to advocate for themselves and speak to the Medicaid show and the group insurance rule, and maybe we get like a step function and improvement in coverage and reimbursement for behavioral health services.
I love that. Kelly, do you want to add?
Yeah. Oh, this is so interesting. I love this because I wasn't aware of the 9902F. And so that is a prior auth is a topic that comes up frequently, and especially for youth in foster care. So, there are, service caps in which you can only get a certain number of individual therapy or whatever the case may be before then you have to request authorization for additional. And so some of them that I've seen, allow kids can only have 25 sessions a year or something like that. When we're talking about youth in foster care, who have some of the highest health needs in the nation, I am struggling to understand why we would cap necessary low intervention, low intensity services like that, when we know those are, support children and help prevent congregate stays and entering into foster care and stuff like that. When we give families what they need, they succeed. And when we set up systems that unfortunately force families to fail up, so they will only get services and supports if they get to a critical level, it's a reactionary approach that is damaging American families. And how do we get a more preventative upstream approach to making sure people get what they need and reducing prior auth? I know in the Medicaid fields, there might be concern about fraud, waste, and abuse. And, I would imagine other ways we can monitor that outside of prior auth. It is administratively burdensome for payer sources. It just, for lower cost services, I just don't understand if it's truly beneficial to add all of that administrative burden.
Yeah, I think it's great. I mean, I think to your point, the use of EPSDT was always meant as early periodic screening and, to deter issues from happening. And so I think your vision, which is to allow people to get the lower cost services early on, I think this feels very, very aligned with. And same thing with the prior auth issue. I mean, what we've seen is that people who have to take extra steps to go get their care, whether that's prior auth or they have to have an additional step to get a referral, are just like significantly less likely to actually effectively go through and do the treatment. And so removing any barrier like this seems like the right move. I mean, I think my question for Andrey would be, it's great to say we want more services, we want, more access, but someone's picking up the bill here.
Mm-hmm.
So I'm curious to take the financial perspective of how does both the increased focus on required EPSDT services, in addition to opening up the the prior auth floodgates, who is covering that bill and who is potentially financially both incentivized to push both of these things, and who is maybe financially incentivized to hold back?
Yeah. So the risk with any fee for service is that savvy operators are going to try to create maximal throughput so that there is maximal reimbursement at the lowest expense possible. It's the American way, for better or worse. Hard stop. That's just fee for service. There's going to be fraud, waste, and abuse. There are imprecise ways of trying to detect fraud, waste, and abuse. Those people that are scammers, they will find ways to scam. The solution here is moving towards risk-based arrangements. So if a provider does a good job, achieves good outcomes, they get paid, or they get paid more. And ideally, providers are able to take as much financial risk as possible within the scope of what they can clinically impact. Which, Patrick, to your credit, the way you're interacting with insurance companies is you're saying like, hey, if we don't engage a member, don't pay us. Cool. Engagement is one of the most effective and consistent measures of clinical outcomes in behavioral health treatment, right? It goes across mental health, it goes across substance disorder. If you engage a member, you're winning the game. Now, Patrick, your business, it's a little earlier on. Another company I had the fortune to invest in is a company called Boulder Care. This is a virtual opioid use disorder treatment provider. Incredible founder and CEO, Stephanie Strong, incredible clinical leadership team. It's literally the, no pun intended, adult version of some things, right? Like some things just like it's earlier business, but some things all the same recipe of great clinical leadership, great founding team, great adherence to evidence-based practice, taking the slow, consistent, patient-centered approach to growth. Well, Boulder just put out a study that was published in the Journal of Substance Use and Addiction Treatment that showed that their approach, which is a virtual approach to treating people using buprenorphine and medication-assisted treatment, was actually more effective than usual care, meaning brick and mortar based medication assisted treatment. And so all of our theories around how a virtual first approach to care delivery, is it safe? Is it viable? Like they're proving not only is it safe and viable, it's like actually more effective, largely because of convenience and a focus on user experience, etc. Well, guess how they get paid? They get paid on a case rate. They get paid if, are they sufficiently engaging the member? Great. That triggers the opportunity to capture case rate. And then if the member is really expensive, Boulder eats the cost. If they do a really good job of meeting the patient or member's needs, keeping them out of an acute care setting, guess what? Boulder keeps the difference. So that is the holy grail of how we get around this whole issue of fee for service and throughput and volume and non-patient centeredness. It's moving towards as much financial risk as a provider can really clinically manage. Boulder's doing it at scale, and some things is like well on its way to doing that. And I credit you, Patrick, for starting with that, with like being value-based forward. The caveat is you can't be a startup and just like take full risk from the get-go. So you have to crawl, walk, run. But if moving towards as much risk as possible is not an objective from day one, all any business or any provider is doing is just contributing to a bunch of throughput and inefficiency.
Kellie, let's go to you. What have you seen on the value-based or alternative-based payment models, and how do you see the overlap with EPSDT here?
Yeah, so I personally haven't seen a ton of innovation or even work when it comes to value-based payments and EPSDT. So what does that mean? Area of great opportunity. And so really, what my primary focus is certainly to increase access to care and to ensure, high quality care. And so, I do think that this is where risk-based contracts and other types of payment arrangements can really start honing in on some of those goals and engage more people, making sure they get the services they need. And so that topic is in that intervention, potentially using those different payment methodologies could be great for providers, could be great for families, but also what are the ramifications if some of these families actually start to get quick access to services? Instead of waiting 6 months, they wait 6 days. And instead of getting rushed or not high quality care, they are getting the best of the best with the highest caliber provider, or the provider that fits their needs the best. And the ramifications of families getting that kind of stuff that they need can be seen for decades to come. But one of the things I wanted to talk about here is this could actually prevent a lot of kids from going to foster care. This could prevent a lot of families from having to experience any type of separation that we know to be so detrimental to children's health. When families have to make difficult choices about sending their kid to some kind of residential treatment, or when families can no longer feel they can meet the needs of their kid or can't keep their other children safe at home and they feel like out-of-home placement is necessary. When families get the services that they need, they can stay together and children can be healthier. And so that, I think, is another amazing opportunity that is afforded to us here.
I want to loop back on one thing that both of you said, which was how families can be proactive and advocate to drive some of these changes that we're talking about. Is it, Andrey, if you had to suggest to families who were either going through an experience with a youth needing behavioral health services or maybe had in the past experienced that, what would you ask them or advice would you give them to help advocate for some of these changes and better policies around
that's a tough one. I think the families that are most affected by these issues are the families with the least resources available to advocate for themselves. I always recommend go to your pediatrician's office, depending on the type of practice you're in and their bandwidth. They may or may not have the ability to support a family in helping to navigate an interaction with the health plan, or if the health plan is not where the rate limiting step is, helping to navigate the state Medicaid program to make sure that they get the benefits that they deserve. And then if there's a state Medicaid program that is unwilling to fulfill the requirements of the EPSDT guidance or sub-regulatory guidance that was put out, that's a time when it's helpful to get our lawyer friends involved. There is the medical legal partnership, which depends geographically if it's available. It's pretty widely dispersed, where lawyers partner with pediatrician practices to advocate for families with issues like a state Medicaid program not complying with sub-regulatory guidance. The scope of that issue tends to be broader than what the medical legal partnership would be able to take on. And so we're talking about class action lawsuits at that point. I think Witt versus United was class action. I'm not sure. But I think what I would offer is if a family is experiencing, or multiple families are experiencing an issue in their state and they can't find a resource, reach out to us, reach out to me. I will help you find lawyers and advocate appropriately. In many cases, you'll be able to find pro bono lawyers to take on this kind of work. And there's also the opportunity for flagging issues like this for audit. States do not like being audited. It takes a ton of time. It takes a lot of money. And CMCS can trigger an audit. So there's almost an escalation pathway before actually pulling the trigger on a lawsuit. There's a threat for an audit. There's also going to the press. No governor wants to be in the press because they're being threatened for a class action lawsuit for denying children access to care. I say all of this having actually gone through all of the motions with a couple of my portfolio companies, because there's one example with a company, just a quick anecdote just to show you that this really works. I was an investor on the board of a company called Blue Cloud. It was a provider of ambulatory surgical services for dental work for kids with complex care needs. It's a mouthful, no pun intended, but these are like really high risk kids that if you don't address their dental work, they could get a brain abscess and die. Like, really important. The thing is, even to do routine dental work, sometimes we'd have to put these kiddos under general anesthesia because they've got developmental delay, they're technology dependent, et cetera, et cetera. In Florida, I won't name the plan, but there was a health plan that at one point had not paid us for delivering care to 250 kids. And like, I advocated for the board agreed, we provide care to these services to these kids for free because that's the right thing to do. Even though it's a for-profit business, we're still going to do the correct thing. And kudos to Norwest Venture Partners, who is the predominant owner of that business, for agreeing to do that and take the financial hit. So I went to the health plan chief medical officer, and they were like, yeah, I don't know. I went to the CEO. They're like, yeah, I don't know, whatever, dragging their feet. And I was like, okay, fine. I went to my friend Beth Kidder, who was a state Medicaid director at the time. I was like, Beth, I know you care about kids like I do. This plan is doing shady things. We're not getting paid. We can only keep providing free services for so long. The next day, she threatened an audit. Within a month, we get $1 million wire because of the audit threat. And so, next step would have been audit, press, federal audit, lawsuit. But so this sequence of cascading up can be very effective for families as well. So if families or groups of families are in a bind in that way and you want that playbook, give me a shout. Patrick has my contact info. Happy to help you advocate.
That is an incredibly generous offer. Thank you, Dr. Ostrovsky, for that. Kellie, let's go to you. I think you're clearly very passionate about the foster care space specifically. Do you want to talk about what you see either foster care organizations or parents, how they can be involved in advocating for better use and better care through EPSDT for their youth?
Yeah, well, Dr. Ostrovsky was completely correct here that many times these people that we're talking about, they don't have the resources, time, energy to understand that they can advocate for these things, and they should. Our child welfare system that's responsible for tens of thousands of children in America today, they're working 18-hour days. This is the last thing they have time for, although it is something I'm sure many of them would be very passionate about. And so our system is just very taxed. One of my thoughts is, a lot of states will require or payers will choose to have advisory councils. Those would be a venue to attend, and a lot, they are asking for member participation to talk about what's going well or what's not. Now, whether those particular councils actually listen and move to do something different, that's could be a hit or miss potentially. But even state Medicaid authorities sometimes will have advisory councils that members can choose to go to and make sure that they have an opportunity to voice their concerns. And certainly, I would always advise people to do that. Again, like Dr. Ostrovsky said as well, legal aid. A lot of parents don't know that there is, legal aid that you can get out there in a lot of states that is pro bono and will help support. And again, like banding together, hearing from other parents or other caseworkers that are in similar positions to you and collaborating together to have a shared voice is always going to be a little bit more effective. Then also I would say the legal community, guardian ad litem attorneys and parent attorneys, their job is to advocate for what's, so I think that is potentially another avenue. But really, I think, these children that we're talking about, they might not be my children in particular, but they're all of our children. They're the children that live down the street from us. They're the children that sit next to my kids in school. And we should be very invested in ensuring that they have everything they need to be healthy adults.
Yeah, I totally agree. And I think I'll answer that from the provider side too, which is I think providers like us can actually take an active role in all of this and advocating at the state level on a legal basis if needed, but also advocating for the families. And I think like building the products, providing the providers, following, helping plans, helping states actually figure out ways to bring novel provider types and effective care models to members. And I think that's a responsibility of the providers too, to be the part of the solution across the chain to actually make this care delivery happen. Let's wrap up there then. So thank you guys. What an amazing conversation. Really, really appreciate it. Dr. Ostrovsky,
Yeah, just really quickly,
any last words?
I think it's important to thank the folks that often don't get thanks in creating this guidance. Their names don't end up on this. Kate Guinness, who's a senior policy advisor at CMCS, played a big role in the state health official letter. Anne-Marie Costello, the deputy director at CMCS, who's been a lifelong advocate for child health. Dr. Jessica Lee, the chief medical officer, who has my former role at CMCS, provides a lot of clinical insight. Her predecessor, Dr. Aditi Malik, and then, of course, Dan Tsai, the center director, who I think since the creation of the program in 65 is probably the best CMCS center director that we've had. So kudos to all of them. Thanks to them if they're listening for this guidance. And thanks, Patrick. Thanks, Kelly.